Okay, Assalamu alaikum جميعا. Dr. Mohammed, I think you can start now.
Okay, so how many are you expecting?
We shared it to all residents.
تمام. طيب يعني we can start الحين.
Yes.
طيب مساكم الله بالخير جميعا. شهر عليكم مبارك. It's very nice to have this activity بحكم انه الله يكون بعون الجميع ان شاء الله انه training اكيد تاثر بالتالي having these lecture ان شاء الله it's gonna have a lot of benefit for all of you ان شاء الله. واذا مستقبلا نحتاج to further lecture في oculoplastic I'll be more than happy to present. فالتوك اليوم orbital tumors. This is very high yield topic, so hopefully I included all of the cases اللي تيجي في oral exam. So we're going to cover benign and malignant, and if you want it to be interactive, that would be nice. Starting with general rules, so you would have some clinical suspicion, and you can formulate a differential diagnosis based on the displacement of any proptosis. So if you have axial displacement, as you can see here, so that means it's going to come from the intracorneal space or the optic nerve or the extraocular muscle. So these are basically the etiologies that may simulate such presentation. And non-axial, this is less common, but you will encounter it for sure. So this is the medial side, and this is the lateral side. This is the medial wall of the orbit. So we have an inferior displacement. That means something coming from here. So that means either from the lacrimal gland, frontal sinus, or something displacing from above, from the orbital roof. Laterally, if there is lateral displacement from here, that means that there is pathology originating here. And that means abscess is more, it will not be covered in this lecture, but most commonly we find ethmoidal or frontal mucosal. Superior displacement, you would think of something originating from the orbital fat, like rhabdomyosarcomas or any soft tissue neoplasm. Medial is a bit rare. I haven't seen anything. Usually the lacrimal gland displays the globe inferiorly. Okay, so this is one of the rules. Now the onset, what about the onset? So if you have a very super acute, very fast acute presentation, that means you would think of something traumatic like emphysema, or hemorrhagic like retrobulbar hemorrhage. Infectious in the case of any orbital abscess or supraorbital abscess. A super acute typical presentation is emphysema. This is a commonly asked MCQ question. The rest is, I'm sure you know it. However, the months and years, you think of neoplasm and lymphoid tissue. We'll cover these, inshallah. The aim of this talk that you will distinguish a phenotype of each entity. So we'll start with this patient. If there's any volunteer, we can start. This is I'm going to give you the history. This patient was complaining of fullness and heaviness and ptosis in the lateral part of his eyelid. He is 60 years old. So if there is any volunteer.
If anyone, yeah, there is Walid Sarhani.
Okay.
So I would like to ask when the fullness started.
Okay, so this has been going for more than 6 months.
Hello, and does the patient have any medical issues, any thyroid disease?
No.
Any neoplastic conditions? Has the patient been diagnosed with?
He's not aware of any.
And has it been progressing? Well, it is stable?
Yes. Progressing.
Okay, and is the patient complaining of pain or is it painless?
It's painless. It's more of a heaviness with ptosis or dropulent.
Any diplopia?
No, but why would you ask for diplopia?
And if there is involvement of the extraocular muscles, it would cause painful eye movement or diplopia.
Okay.
Right. Then I'll proceed with examination.
Mm-hmm.
Examination, as you can see in the picture, there is fullness and there is mechanical ptosis of the left eye. I would do palpation, check the extraocular motility, VA, APD, check the optic nerve function, including visual field and color vision as well. And also I would make sure that I will invert the upper lid to check the lacrimal gland and measure if there is any proptosis with Hertel's exophthalmometer.
So what are you looking for lacrimal gland?
Lacrimal gland, I want to rule out any enlargement of the lacrimal gland.
Okay, what else?
I would make sure that there is no salmon patch at the area of the...
No, the conjunctiva didn't show anything. So what else you will assess?
And then after I finish my examination, I will proceed with imaging.
No, but before, في missing elements. يعني مثلا الهيرتل exophthalmometer, did you mention it?
Yes, I mentioned the Hertel exophthalmometer.
تمام. Elevator function.
Elevator function as well as the palpebral pressure.
Let's say that the elevator function is normal, meaning that it's more than 15. The decrease, as you can see, it's symmetrical.
Hello.
So
the ptosis is mechanical.
Could this be a ptosis, a simple ptosis?
No, I think this is more of mechanical ptosis.
Why is that? Why would you suspect something like that?
Because there is fullness in the area of the lacrimal gland. Elevator function is intact, so which goes against the paneurotic ptosis. Okay,
so I always like to, whoever had training with me, I always stress the fact that if you have a normal elevator function and symmetrical looking lid crease, why would you have ptosis? If there is no neurogenic cause like Horner or any palsy of any like third nerve or if there is Horner, why would you have ptosis? So you need to rule out mechanical. Okay, so pupil is important also, and fundus exam, all of these things, you have to mention them. Now you'll do imaging. So what type of imaging you will do?
I would start with CT imaging with contrast.
So why would you do contrast?
Because I'm not sure of the underlying etiology.
Okay, so this is the CT scan. Can you describe it?
So this is an axial CT scan with the contrast showing irregular.
So which window is this?
This is a soft tissue window.
Excellent.
irregular enlargement of the lacrimal gland extending into the intraconal area.
So just a tip, never mention lacrimal gland in CT scan. It's very difficult to distinguish. If you want to assess lacrimal gland etiology, always request MRI. Okay, so you can just say that, describe this homogeneous mass.
So it's a homogeneous mass of the lateral part of the orbit extending into the intraconal part with irregular margins.
It's not clear if it's intraconal. I know this is a superior cut, but you can just say that it's occupying the lateral orbital wall from the greater wing, from the sphenoid bone to the part to the edge of the zygoma and enroaching the globe. So what else? There is a key word here. So what do you think?
Molding effect surrounding the globe.
So this is molding, huh? Okay, good. So what's the most likely diagnosis?
So the most likely diagnosis here is a lymphoproliferative disorder, benign lymphoid hyperplasia or lymphoma.
Okay, excellent. So lymphoproliferative, can you distinguish from benign or malignant based on these two pictures?
The only way to distinguish between benign lymphoid hyperplasia and lymphoma is pathology.
Excellent. Okay, good. You're which year?
R3 KSU.
Oh, mashallah. Okay, excellent. So you're correct, lymphoproliferative disorder. So in order not to confuse this disease, so it can be divided into a nodal. We don't deal with it as ophthalmologist. It's rising with lymph node, lymphatic tissue. What we deal with is the extranodal. And it's a very huge spectrum under the ocular adnexal lymphoproliferative disorder. And so the most confusing part that I see when I discuss lymphoma is to differentiate between the ocular and the intraocular. So the intraocular is different than the ocular. So the ocular, it's what we deal with as oculoplastic. It arises from the conjunctiva, eyelid, orbit, lacrimal gland, and lacrimal sac. And most commonly, it's B-cell origin. Okay, it's 95%. However, the intraocular, this is mainly dealt by ophthalmologists or retina. It's basically an extension of the sinus lymphoma. Okay, this is what you have to know. So it affects the retina, uveal tract, vitreous body, optic nerve head, and again, it's almost always B-cell lymphoma or B-cell origin. So you have to know these this differentiation between these two entities. So intraocular lymphoma is basically an extension of sinus lymphoma. However, ocular adnexal lymphoma is what we deal in oculoplastic. So benign versus malignant. The benign has a lot of spectrum, include reactive lymphoid hyperplasia, IgG4, and the keyword is in MCQ's questions and also in the exam is polyclonal. Ocular adnexal lymphoma, again, the keyword is it arises from monoclonal expansion of malignant B or T lymphocyte. Okay, so polyclonal, that means when you see the slide, you will see different types of cell. However, monoclonal, you see one type. This is very important. So always in exams, you have buzzwords or keywords that if you mention, you make the examiner understand that you know what you're talking about and you know the answer for sure. If you mention all of this, this is okay, it's correct, but you need to be smart about these things and memorize these keywords. So this is the features of and classification of lymphoma. So Hodgkin lymphoma, we can just get rid of it because we don't deal with it that often. So we'll concentrate on these. Okay, and again, Dr. Walid, he mentioned that you cannot differentiate between or malignant with clinical presentation alone or imaging, unless if you have bone destruction and signs of malignancy. However, biopsy is the gold standard when it comes to diagnose these cases. So what we deal with is mainly I see these types. This one, and this one. Mantle cell lymphoma, maybe I encountered one case. So I don't think you need to memorize these, but at least you know that there is different entities, and the only way to differentiate between them is with biopsy. So this one is obviously malignant. So doing a minimal biopsy will help in diagnosing what type of lymphoma is this one, instead of doing a radical surgery. Okay, so features of imaging. So again, the keyword is molding. Aggressive lesion, as I showed you in the previous picture, there will be erosion and destruction to the adjacent cranium, sinuses, skin. And if there is such extension, MRI will be very helpful to delineate that extension. So just to stress on the molding, this is the molding. So when we say molding, that means it كده تحاوط أو يعني it surrounds the tissue without causing any angulation. You can see the globe, it's not indenting at all. And there is no irregularities في sclera. So this is very important. This is what we call molding. In the coming slides, you will see the difference in some areas, in some pathologies. Okay, so usually when I do these cases, if I'm suspecting lymphoma, I coordinate with the pathologist. And I discuss with the pathologist on what are the best biopsy specimen that he or she will need. So mainly you need a fresh for flow cytometry, and you need other for immunohistochemistry and genetic mapping. So usually I debulk safely and prepare a fresh as well as formalin. This is the routine. Sometimes the pathologist cannot identify the exact subtype of the lymphoma, of the lymphoproliferative proliferation. So it can be polyclonal, or sometimes it doesn't meet the other diagnostic criteria. And these are labeled as reactive lymphoid hyperplasia or atypical lymphoid hyperplasia. Those require systemic workup and long-term follow-up. This is very important to mention also in the exam, the staging and investigation. Okay. Prognosis, this is an MCQ question mainly. So systemic involvement is more associated with eyelids, followed by orbit, then conjunctiva. Treatment, multidisciplinary. So if there is need of shrinking the mass, sometimes the patient present with, like the patient I presented to you, will definitely need radiotherapy because it's causing ptosis, droopy lid, as well as mechanical effect. So radiation is the mainstay of treatment. So if it's confined to the orbit without evidence of systemic lymphoma, radiation therapy is sufficient. if systemic lymphoma is found, chemotherapy is usually initiated. There is a debate in this issue, the bilateral orbital disease without systemic disease, will it warrant a systemic chemotherapy? This is where the oncologist or radiation oncologist role, they come into place in these scenarios. You don't need to mention the scenario, and this is not a common one. After that, you need to closely follow up the patient, as systemic disease may develop years after treatment of the primary orbital lymphoid tumor. If local recurrence develops in a previously benign biopsy, you should repeat it to rule out malignancy. Clear lymphoproliferative? Any question regarding lymphoproliferative? If you have any question, please do ask. Mshahil, no one is raising?
No, and no
Okay.
questions on the chat as well.
Tamam. Okay, volunteer. So this child, highlight the child, as the mother noticed that there is change in the eye shape of the left eye, and that's it.
إبراهيم المنصور wants to answer.
Sure.
تفضل بس.
السلام عليكم، تسمعني دكتور؟
هلا ابراهيم، هلا والله.
حياك الله، كيف حالك دكتور؟
الله يحييك.
Okay. First of all, how old is this child?
So this is an 8 years old.
8 years old. Okay. Noticed by his mother to have these changes in his eye.
Yes.
Okay. This is an external photo of a child showing left eye dystopia. There is no clear swelling with quiet eyes.
Left, huh?
Yes.
Okay.
I would start with the history, asking about these changes. When did it start or noticed by the mother?
So it's been there for a long time, but they're not sure, but it's progressing.
Okay, so a few weeks, months. Okay. Plus, the child is complaining of anything. I mean, pain, itchiness, any discharge, or any eye problems or complaint.
No, vision is okay. You have to mention vision. Only this asymmetry.
Asymmetry. Okay. Medically free.
Yes.
Any family history of any pathology, mainly tumors?
No.
Okay. No history, definitely, of trauma.
Why would you ask about trauma? You're thinking of something?
It could be a vascular lesion.
So how come trauma is related to a vascular lesion?
It might cause, first of all, CC fistula or varices.
Usually, it's again. So I brought specific cases, so we know the phenotype of each disease entity. So if you want to ask a question, be careful, and some examiner will get irritated if you ask a question that has no lead. So trauma, there's no trauma, and I don't think there is a use for such.
Plus the fracture, if there is, floor fracture.
No, all of these. We'll proceed to exam.
Okay. I will assess the optic nerve. Before that, definitely I will inspect and palpate the area. If there is any well-defined mass, its consistency, ability, its depth.
Excellent. Okay. So just to make things faster, so all the exams, the full examination is within normal limit. It's basically the same the same parameters that Dr. Walid mentioned. Okay,
Yes.
so what will you do next?
I will image this child.
Okay, what imaging you have in mind?
I'm preferring doing MRI.
Okay, you can do CT scan. It's cheaper, faster. If you need MRI, cost it after that. So
Doctor,
CT scan.
in general, routinely, I have to start with CT in general. حتى لو كنت I'm suspecting already suspicion of tumor or soft tissue mass is highly.
Yes, yes. If you don't want to, this is there is different different practice among physicians, but sometimes the radiology will recommend MRI after you request CT scan. I remember the radiologist back when I was in KKish. I used to do CT without contrast, followed by MRI with contrast to have a full picture. So doing CT scan, if you want to do it without contrast, especially that there is no infection, no signs of vascular malformation so far, you can start with CT scan. I mean, CT scan is cheap, faster, and MRI is expensive and takes longer to do. So I would do CT scan.
So in general, to start with CT scan.
CT scan. No one will. I don't think anyone will blame you. So this is the
Okay, so CT scan, the coronal cut and showing clear sinuses, normal around the globes, and I can see thickening or spacing in the left frontal bone mainly.
okay.
Yes. Homogeneous. I don't think so. This is because it's not hyper dense.
Sorry, I didn't catch. You don't think what?
I don't think this is hyperosteosis. There is thickening in the frontal bone, but it's not hyperosteosis because the bone itself is not hyperdense in comparison to the other bones.
Yes. So this is a typical. They call it ground glass appearance.
Yeah.
So what's the most likely diagnosis? Any differential comes to your mind?
Yeah, top of my differential child, and this changes in the bone, fibrous dysplasia.
Okay. طيب, any differential diagnosis? Any similar condition that may simulate this CT scan?
Leukemia, maybe.
No, not leukemia.
I'm not aware.
Okay. So yeah, this is fibrous dysplasia. So it's commonly present in childhood. The most common symptom is facial asymmetry. However, they can develop visual loss, ptosis, or globe displacement, especially if the dysplastic bone is growing anteriorly. So, what are the vision loss causes, Ibrahim, in fibrous dysplasia? So imagine that you have a dysplastic bone that grows around the orbit. So
Compression on the optic nerve in the optic canal.
okay, so if the optic canal has a dysplastic bone.
Yeah.
Okay.
I'm not sure if it can infiltrate the optic nerve itself.
No, but it can cause traction because you will enlarge the canal, and this will stretch push the nerve and may cause traction. Okay, so this is a textbook answer, but the most common that you will find is or may encounter is optic nerve related, like optic nerve traction, encasement of the optic canal by the dysplastic bone, or stenosis of the optic canal. Orbital compartment syndrome is usually a late stage. Okay. What about the associate syndrome?
I forget the name. There is.
Anyone knows? Syndrome?
Bright or.
Okay, so it's called McConnell-Bright syndrome.
Yeah.
So it's present in polystotic disease. When we say polystotic, that means it affects more than one bone. And it's associated with cafe au lait spot and precocious puberty. That's why it's useful to ask the parents and examine the child if they have any cafe au lait spots, and ask about puberty compared to his or her brothers and sisters. So this is mainly polystotic disease. The orbital part of fibrous dysplasia usually gets affected. The frontal bone gets affected, and it's somewhat monostotic disease. However, if there is more than one bone, you would think of McConnell-Bright. So always look for that syndrome and refer the patient to endocrinology. I can hear my echo. If someone can kindly mute the mic. Okay, so treatment depends on the what you have. So there is pain or any deformity of the structure. There is any structural deformity. Then you need to restore it, and this is difficult, easier said than done, but a complete resection with simultaneous bone reconstruction is the definitive treatment, and this is usually done by neurosurgeons and maxillofacial as well as oculoplastics. Systemic steroid, usually it's used if there is any signs of inflammation or vision loss, and if you see stenosis in the optic canal, then a neurosurgeon role is very important by doing prophylactic transcranial decompression. And this should be done only if there is documented visual loss. The prophylactic part of this procedure is still under debate. This is a rare disease, so there is no clear guidelines. The most commonly affected bone in the orbit is frontal. However, if the sphenoid bone is involved, you need to closely follow the patient because it can cause visual loss. The decompression, transcranial decompression, there are several reports that they reported that there is visual recovery after that procedure. And again, the monostotic part is isolated skeletal dysplastic changes in single location. This is the monostotic. However, the multiple location, it's called polystotic. And when you find this subtype of fibrous dysplasia, always look for McConnell-Bright syndrome. Okay, any questions regarding fibrous dysplasia? Clear?
Dr. في one question في الchat. Aisha, she's asking if we can consider bone infarction in cases of sickle cell disease as a differential for the CT findings of fibrous dysplasia.
You can see that the patient had a quiet eye and quiet orbit, so I wouldn't include sickle cell infarction. So sickle cell infarction, if you have a picture of orbital inflammation, always include it in the differential. Okay. So any volunteer? This child.
دكتور محمد تسمعني؟
تفضلي. مين؟
انمار. دكتور عندي سؤال على
لا حياك.
الله يحييك. إذا ما عندك مانع، بس الإيمجينج من قبل مو مفروض إن تكون hyperostotic يعني more bright on the CT، ولا مع الكونتراست تصير شكلها more bright الفايبرس dysplasia؟
Sometimes fibrous dysplasia can be missed if it's in early stages. So the bone window is the most important window to detect these dysplastic changes. So no, usually they present like this, ground glass appearance. The hyperostosis can be can manifest, but it's not as pronounced or true hyperostosis compared to other entities. I'm going to come to that. So usually it's more of a ground glass appearance. There is trace of hyperostosis you may find in some bones. This is true, but mainly it's ground glass appearance. So the simple answer is yes, you may find hyperostosis in some areas of dysplastic bone. Okay. I asked Ibrahim على differential diagnosis. This is a fellow question. There is a disease called ossifying fibroma, and this there are several differentiations can be done between fibrous dysplasia and ossifying fibroma. But this is a fellow question. You don't need to know it as for resident level. So I hope this answered your question, Anmar.
يعطيك العافية. شكرا دكتور.
So this child, okay. So again, the parents reported swelling and also pain. That the child is complaining of referred pain in the upper part of this area. So any volunteer? Jan, في أحد؟
No one is raising his hand.
Okay, go ahead, Jan. Moderator.
You can pick one.
I don't have the list. So.
طيب, Anmar is raising her hand.
Sure.
Okay. تفضل يا أنمار.
Okay, so I'll start with history, doctor.
Sure, yes. So the brief history I gave you, that the parents reporting swelling and the child is also reporting referred pain in that area.
Okay, so how old is this child?
5 years old.
And when did this start, and is it progressive?
It's progressive and it started about more than 1 month.
More than 1 month. Any previous episode and any history of trauma or surgery?
So no trauma, no surgery.
Okay. No trauma, no surgery. I started 1 month, يعني not noticed since childhood.
What are you thinking about when you said since childhood?
Dermoid.
Okay, excellent. No, it started about a couple of months, 1 to 2 months, and it's progressive.
Progressive and painful. طيب. I don't have any more questions for history. Can
sure.
I move
So
on?
what will you do?
So I'll check for vision, amblyopia, extraocular movement, APD, intraocular pressure as well.
Okay.
Yes, and Hertel as well. I would like to palpate this mass to see if it's
tender.
Tender. Is it confined to one space? Is it fixed to underlying tissue? Is it erythematous or warm?
Difficult to tell. There is no signs of inflammation. However, it's only tender. But there is a mass, palpable mass.
Okay.
So what will you do?
Imaging. I would order CT.
Okay. So this is the CT scan. What do you see?
Okay. So, this is coronal CT scan. Looks like a bone window with the mass superior temporally.
So just to compare between the fibrous dysplasia, this is the bone window.
Sorry, the soft tissue lesion.
Okay. So coronal soft tissue window. Okay.
Okay, I can see a mass superior temporally It seems like it's invading the bone as well, superiorly.
Okay, so there is a bone defect. Okay.
Yes. The mass itself looks homogeneous and well circumscribed to me.
Okay. And it's not displacing the globe.
And not displacing the globe, no.
Okay, so if you want to characterize more the lesion, there's no harm of requesting MRI. So again, this is the MRI, and again, it delineates more. So whenever you have a mass near the meninges or near the intracranial cavity, better to request MRI, because if you want to do the surgery, you need to know if there is any connection in this area. It's really dangerous and hazardous as an oculoplastic surgeon to go in this area without knowing what's happening here, because you need to be prepared and have a neurosurgery standby if needed to. So you can see it's not connected to the brain.
Yes.
Okay, so again, my talk will stress on identifying phenotypes. So you have a child with superior temporal swelling and pain and proptosis. So what diagnosis do you think of when you see this scenario?
Could be from a simple diagnosis, a ruptured dermoid, but it wasn't there since childhood.
Okay, so ruptured dermoid, if there is history of prior inflammation, yes. Ruptured dermoid is an excellent differential. What else?
Lacrimal gland adenoma or adenocarcinoma, since it's close to the lacrimal gland. Inflammation or adenitis, since it's also superior temporally.
So there is no signs of inflammation, so I wouldn't. But inflammatory pseudotumor, if there is signs of inflammation, yes, you can include it. Carcinoma, it's not. Again, he's a child, so you wouldn't think of epithelial lacrimal gland neoplasm for sure. This is not the age for lacrimal gland neoplasm. So ruptured dermoid, inflammatory pseudotumor. Okay, what else? So any bone neoplasm. You have a bone defect. You can think of any bone neoplasm, either sarcoma or leukemia.
Yes.
Okay. So what's the most likely diagnosis?
Between sarcoma or leukemia,
No, no, it's not this. It's another. I'm sure the one who are KSU program, they will answer this. So anything comes to your mind? No. Okay. So any volunteer, anyone who knows what's the most likely diagnosis? Msha'il, anyone raising their hand?
No, but they're writing on the chat. Eosinophilic granuloma. Okay,
good. Excellent, Anwar. So this is Langerhans cell cytosis of the orbit. This is an entity where there is proliferation of pathological Langerhans cells, and it manifests possibly unisystem or multisystem. And it can involve the bone as well as different vital organs, brain, lungs, liver. It can be isolated. However, localized lesion of the orbit or to other bones are formally referred to as eosinophilic granuloma. So yeah, correct. Who answered the eosinophilic granuloma? Do you know?
Yeah, Iman al-Sharif, Mohammad Khalifa.
Oh, okay. So yeah, I'm sure the university group will answer this. Okay, so any associated condition? Anyone? ما في volunteer. مش عارف في أحد.
Yeah, let me just دكتور مهند الخليفة I'll unmute you so you can answer.
Sure.
تفضل.
I'm thinking of Erdheim-Chester disease, which is a lethal disease.
Okay, it's a subtype of Langerhans cytosis, but it doesn't manifest like this. But yes, it's one of the types of. So what else other than that?
The Langerhans cytosis.
Hey.
I remember a lot of names, but I forgot it. They are both now grouped as one disease, which is the granuloma of bone.
Okay. You're in which program?
KSU.
Okay, good. إن شاء الله KSU كثير يشاركون. So mainly it's diabetes insipidus. Okay. Just excuse me for a minute. طيب معليش sorry. Okay, so especially in diabetes insipidus, you find it in hand, shoulder, Christian disease. Okay. As you mentioned, there are other. It's again, it's a spectrum of diseases. So histiocytosis X, it's a general term, and now there is also a disease which the one you mentioned, the little Sphenoid disease. This is the lethal form. And there are reports older than infants, but typically it presents in infants. That's why I was looking for this answer. So differential diagnosis, Dr. Anwar, inshallah, she highlighted most of the differentials. So ruptured dermoid cyst, hematoma, you can include the sickle cell, possibly, sickle cell infarction, inflammatory pseudotumor, leukemia, osteosarcoma, metastatic neuroblastoma typically present at a much younger age, usually 2 to 3 years. Rhabdomyosarcoma can present, the average age is 8 years, so 5 to 8 years, you can include rhabdomyosarcoma. It's very important to know the age groups in these two entities. Okay, so treatment, very important to consult pediatrician. Again, for multifocal disease, Dr. Khalifa mentioned, and diabetes insipidus. The goal of treatment depends on the location, and the most important part of the treatment is the systemic involvement. Usually, the isolated orbital mass can be removed easily with intralesional steroid. However, there are some reports regarding posterior and large orbital lesion. They recommend to be treated with chemotherapy. And long-term follow-up is important as recurrence can happen. And again, Dr. Khalifa mentioned the disease, and this is the fatal part. It usually comes to children less than 3 years of age. Okay. So any question regarding fibrous, histolytic lesions? Dr. Mohammad? في حد raising?
نمار.
Okay.
سامي مشاعل تراني ما شاركت بس إيش؟
أوكي هذا أجل ألا ورير عند.
طيب any questions طيب؟
no
أي أحد؟ تمام. طيب يلا volunteer. هذه this is a 50 years old lady complaining of blurry vision and asymmetry of her eyes. Oops. Okay, go ahead. Any volunteer? مشاعر anyone raising their hand.
وليد السرحاني already جاوب. نبغى
لا نبي أحد new
other
please. How many are attending الحين?
89.
ما شاء الله. Okay, now I'm gonna feel stressed. Huh? طيب. So, any volunteer? Let's see. دكتورة حنان شعلان موجودة؟
حنان أي موجودة.
أوكي. دكتورة حنان.
تفضلي حنان.
السلام عليكم دكتور.
لا تفضل حياك الله.
This is
Okay, so again, this is a lady in her 50s complaining of blurry vision as well as
diplopia.
There's no diplopia, blurry vision with asymmetry.
So I want to ask about onset and duration of symptoms. Is it progressive with time or not?
Yeah, progressive, painless for 1 year.
Mm-hmm. Is there any history of previous surgery or trauma?
No.
Does the patient have any medical conditions? Is she diabetic, non-thyroid disease?
No.
Known to have any malignancy or family history of malignancy?
No. So anyone ask about malignancy, always mention the constitutional symptoms. So okay, let's move to examination. So she has the vision is 2100 and and there is APD. And the optic disc is paler compared to the other eye. We're talking about the left eye, okay?
Yes. I want to test extraocular motility, color vision, visual field.
Color vision is affected. Visual field also there is constriction. So what will you do?
So she has a dysfunction of the optic nerve function in the left eye. Yeah. I want to do Humphrey visual field and I want to do imaging.
Okay, what imaging you will do?
I will start with CT scan with contrast.
So can you describe this CT scan?
So this is the CT scan bone window, coronal cut.
Coronal?
Sorry, axial cut. Showing enlargement of the sphenoid wing in the left side.
Excellent.
There is a hyperproliferation of the bone with no bony defect and no other lesions.
So what do you describe this bone?
So it is a hyperostotic enlargement of the frontal wing in the left side.
Okay, so hyperostosis. So you can do MRI to delineate more in this area.
Yes.
طيب. So what's the most likely differential?
So most likely differential is the sphenoid wing meningioma.
تمام. Okay, excellent. So yeah, it's a sphenoid wing meningioma, and it's a secondary tumor originates from the dura of the sphenoid wing, and with a gradual extension to the orbit. Okay. Average age is 50 years with higher incidence in females. Symptoms, the typical symptoms are progressive proptosis. It's the most common symptoms associated with different of symptoms, but mainly progressive proptosis and blurry vision with optic nerve involvement. So you can see the trend in my presentation that I'm trying to, because this is applicable not in exam, also clinically. There are specific phenotypes that you need to know, because common is common, okay? And you need to concentrate on what's common. So what's the causes of, different causes of hyperostosis, Dr. Hanan?
We can categorize them into inflammatory, neoplastic, or congenital malformation, maybe.
Well, I'm not aware of specific entities. So,
Like,
what are...
so maybe fibrous dysplasia is
Okay. And
is congenital.
lymphoma.
Yes.
Okay. What else? One more. So metastasis, orbital metastasis, also it's cause of proptosis. So yes, sphenoid meningioma. Sorry.
Can we consider infarction in case of sickle cell anemia?
I'm not aware that it causes hyperostosis. Usually it causes expansion of the bone, and it's not hyper. As far as I'm aware, it doesn't cause hyperostosis. I don't know. No, it mainly causes enlargement of the sphenoid wing because you have a repeated proliferation of hematopoiesis of the RBCs. So it's mainly enlargement.
Okay.
And why is it in the sphenoid? Because it's the largest surface area of any orbital bone.
Okay.
So no, I don't think it causes hyperostosis. Could be wrong though. If you have anyone has a comment, but this is mainly the three causes. So management is a neurosurgery consultation, and this should happen in coordination with the neurosurgeon. So observation, surgery, plus minus chemoradiation treatment should be done in coordination with the neurosurgery. Okay, so since there are no many volunteers, let's see. Kasr Thabit, is he here? Sorry. No, let's go to the other case. This is just an example. No, actually, no. Let's take a volunteer. Yasser bin Thabit, is he here?
Yes, he's here.
Okay. So this is a 70 years old male with pain, swelling in the left eye. So what's the differential diagnosis?
So the differential diagnosis, the top differential diagnosis, doctor, to rule out orbital cellulitis.
So there is no signs of infection. He is afebrile and no tenderness or hotness upon palpation. There is only this diffuse swelling with mild tenderness and proptosis. So what else other than infection? And the onset is chronic. It's been there for the past month.
Okay. Could be idiopathic orbital inflammations.
Okay. So he's 70 years old.
Could be we have to rule out as well mucormycosis.
Okay, so other than infectious etiologies?
To rule out also tumors as well.
Okay, so what imaging will you do?
I would start by CT, plain CT, or we can ask CT with contrast.
It's not that clear, but you can see the coronal soft tissue window or bone window. Actually, it's not that clear. So, but what can you see on the left side here?
I can see there is a soft tissue mass on the up of the superior part of the orbit,
okay.
Pushing the orbit downward.
Okay.
and also.
So what about this area?
And also with the and also infiltrating the bone as well, the superior orbital floor.
So there's bone destruction. So
Yes.
Okay. So what's the main, the most likely diagnosis?
So I have to rule out the malignant tumor in this case. So I have to rule out, for example, the metastasis or
excellent.
Any. I have to rule out the lytic
So
lesion.
this is another patient. Old. Describe the bone here, please.
It looks like this hyperosteosis of the bone. I don't see any destructions.
Excellent. So other entity that causes hyperosteosis is metastasis. Excellent, Yasser. طيب. So metastasis to orbital bones, common primary site in men, typically, this is very important, lung in men and breast in women. In children, mainly the common metastasis is neuroblastoma, followed by soft tissue sarcoma and rhabdomyosarcoma. And when you do histopathology of the biopsy of the mass, you will find the histopathology consistent with a primary malignancy. Okay, let's see. Yasser Thniyan is here.
Yeah.
By the way, السيشن إلى متى ودكم؟ لأنه it's very I have a lot of slides. So إلى أي وقت تبون؟
whenever you want. في session هو الحين بتبدأ الساعة 10. So anyone wants to leave.
session إيش؟
glaucoma.
Okay. Because still I have many slides. So what should we do here?
Either we can continue or rearrange for another session.
I don't mind continue, but continuing the session depends on the أغلبية الناس وش يقولون.
طيب, let's see.
I don't know if you, I think you can do a vote, no?
Yes.
Okay. Let's do a vote. I don't mind continuing the session, but still I have plenty of slides. You know, it's not an easy topic to cover. So let's, because still I don't think we covered a lot.
دكتور.
Yes.
الله يسعدك، معليش على المقاطعة، أنا آسف. الأفضل أن نقسم المحاضرة إذا ما عندك مانع إلى جزئين، لأن ما ودنا يعني محاضرة الدكتور الشمراني برضو ودنا يكون فيه حضور يعني. أنا أغلب الشباب هنا يصوتون على كونتينيو، ما عندي مشكلة، ما ودي إني أطلع على الدكتور الشمراني، فهمت علي؟ ولا براحتك مرة، ما عندي مشكلة.
Okay, so we'll continue. The most of we'll continue. Okay. طيب Yasser Thniyan is he here?
Yes. Yasser, you're unmuted. تفضل.
So yeah, this patient, middle-aged woman with asymmetry, and she's feeling heaviness in this area for almost 9 months, more than 9 months. So just to make things fast, I'm gonna proceed to because you all covered history and exam very nicely. So there is a palpable mass here displacing the globe. So you can see the globe is displaced inferiorly. What's the differential based on this displacement? What's the differential that you have in mind, Yasser?
Okay, Dr. Mohammad, thank you for the excellent lecture. I would think about vascular lesions that would cause pulsation in the area.
Okay, so there is no pulsation. However, yes, anything that's chronic, always think of vascular. Okay, so vascular related, like what?
Whether it was hemangiomas or lymphangiomas, lymphoproliferative, vascular malformation in general.
Okay, other than that?
Also, I would think of
so what other etiologies that can originate here and cause displacements?
Also, I would think about etiologies related to the anatomy in the area, like lacrimal gland.
Okay, so lacrimal gland, what's the differential diagnosis or the diagnosis related to lacrimal gland?
I would think about lacrimal gland prolapse would cause displacement.
Prolapse usually doesn't cause displacement. Prolapse we see commonly when we do blepharoplasty, simple prolapse. However, this is a displacement, not a simple prolapse. So no, other than that.
And also tumorous malformation of the lacrimal gland. Like
what? So 9 months, painless. What's the possible diagnosis if it was a lacrimal gland?
I would think of adenoid cystic carcinoma of the lacrimal gland.
Painless and again, painless and 9 months. It's unlikely to be adenoid. Anyway, this is the CT scan. So can you describe what you see?
Okay, this is a coronal section of the CT scan showing soft tissue window, hyper density of the superior temporal area of the left side, extracornal,
okay,
pressing on the superior recti and also the lateral rectus. I think also I'm seeing, yeah, part of the optic nerve here also.
So what's the differential diagnosis?
So now it's more, and also there is bony changes also in this section.
So what kind of bony changes do you see?
I would say taking the shape of the bone. Like,
okay, so this is very important. I'm sure many of the residents who rotated with me, I'm sure Dr. Msha'al also knows, we discussed this recently, that if you have a long-lasting orbital mass, so this is the orbital mass, these bony changes, it's bone remodeling and excavation with bone expansion. Okay, this tells you that this mass has been there for a while. Okay, it's very important. You see this in extracornal cavernous hemangioma, lacrimal gland tumors, benign ones, and also long-lasting orbital dermoid. Okay, so what's the most likely? You have a middle-aged female with almost 9 months history of painless mass. So what's the most likely diagnosis? Anyone? Any volunteer? Child?
Yes, the writing on the chat, polymorphic adenoma.
Okay, excellent. طيب. I have the slide number as you can see here. Let me check. When I'm halfway through, I'm gonna stop. I think so, and hopefully we'll reschedule it anytime you want. Like الساعة المباركة. طيب, let me just okay, so that means I will see. Okay, so let's cover the lacrimal gland. Okay, and
yes,
we'll stop there. I think that's fair, and hope we'll continue later.
Arrange for a second.
Yeah, second session is going to be much shorter.
Okay.
Okay, so yeah, correct. This is the lacrimal gland mass. It's a polymorphic adenoma. Just one thing again. So see how it pushes the globe. So lymphoma doesn't do this. Okay, again, many people they say molding without knowing what molding means. So in lymphoproliferative disorder, molding, the rearrangement of the mass and enroaching of the mass around the globe or the bone. Usually epithelial masses cause angulation and mass effect. تمام? So this is how to differentiate between polymorphic adenoma and lymphoproliferative disorder and lacrimal gland when it comes to lacrimal gland. Okay, so the typical phenotype, again, it's third to seventh decade. It's the most common benign lacrimal gland epithelial tumor. And so again, common is common. It's most commonly arise from the orbital lobe. It's the typical history is painless, progressive, slow growing, and usually it's 1 year, more than 1 year. The pathology, again, this is I'm going to send this presentation to Dr. Msha'il. Pathology, this is an MCQ question. It's mainly 2 cells. Okay, so CT scan, as you saw, well-circumscribed mass in the lacrimal fossa with bone expansion and excavation. And there is no bony destruction. Treatment is complete. I highlighted it with and underlined this, that you should remove it completely without, with no preceding biopsy. The prognosis is very excellent with the total removal, and it only recurs if there is incomplete excision. And if that happens, there is a chance that it can have a malignant transformation. So again, just to stress the phenotype of each disease. I remember Allah يذكره بالخير, Professor R, one of the most beautiful things that he used to do in uveitis is highlighting and delineating each phenotype for each disease entity, because common is common again. So if you have bilateral involvement of the lacrimal gland, this should suggest inflammatory lymphoproliferative process. However, an epithelial lesion, it's very rare to have bilateral involvement. Okay, so always have this rule in your mind. Okay, so 4 more slides and we'll stop. So we have this patient, okay. So it's 3 more conditions. Okay.
So one question regarding the previous case from Hala. She's asking why the eye is displaced laterally since the tumor is lacrimal gland origin.
This patient, that's an excellent question. This patient, I was on call and I saw her in a glaucoma clinic, and this is the bad eye. So she has sensory XT. Who asked this question?
Hala.
Hala إيش?
I don't know her صراحة.
Which program?
I don't know.
Excellent, very attentive, mashallah.
Sharqiya.
Okay. Usually, attentive physicians go to oculoplastics. Okay, so any volunteer? So this patient, he noticed asymmetry. He is 6 years old. Let's see. If there is no volunteer, I can pick any name. نواف المقبل, is he here?
Yes.
هلا دكتور.
هلا والله.
كيف حالك؟
كيف حالك؟ من زمان عنك.
الله يسعدك, الحمد لله.
الله يحييك. Okay, so this patient has asymmetry and noticed that this eye is different than the other eye for almost, let's say, 1 year.
Okay, so is it associated with pain?
No, it's painless, not affecting vision.
Okay, is it recurrent or the first time?
It's the first time.
Okay, is it enlarging in size?
He noticed the past year that there is progressive asymmetry between the 2 eyes.
Okay, he's medically free?
He mentioned history of chest neoplasm, which was treated in USA.
Okay.
These are real scenarios. Okay.
Okay. Is there I'll proceed to examination.
So just to make things much faster. So examination, inherent exophthalmometer, there is proptosis in the left eye. The rest of the exam is normal. So what will you do next?
He doesn't have any constitutional symptoms like fever, weight loss?
That's an excellent question. No.
Okay. He received the chemo or radiotherapy, doctor, for his?
Not clear, but he received IV treatment. Most likely it is chemo.
Okay. And no ABD, you said?
No. The only thing, proptosis with the full motility.
Okay.
Yeah.
So we can proceed to imaging.
So this is the imaging. What do you think? Just describe and the most likely diagnosis.
Okay. So this is a coronal CT with the soft tissue window. There is a mass at the superior lateral edge of the left eye.
Okay.
Hyperdense mass, homogeneous. It's causing molding effect.
Excellent. So again, I want to stress the molding because many people, they just memorize and don't know what it means. So you can see how nicely it molds around the globe without causing any mass effect or angulation, to be exact. So again, Dr. Ibrahim al-Mansour once asked me that how come that the orbit has no lymphatic tissue, yet we see lymphomas. So interstitium of the lacrimal gland and substantia propria of the conjunctiva are capable of undergoing hyperplasia. You have mucosal associated lymphatic tissue, which is in the conjunctiva, and the conjunctiva is connected to the lacrimal gland in the superior lateral fornix, where the palpebral lobe ducts ends there. So this is one of the theories that the lymphatic tissue extend to the lacrimal gland through this route, as well as metastasis. So again, the spectrum from reactive lymphoid hyperplasia to atypical lymphoid hyperplasia to malignant lymphoma. Just to stress this point, it's difficult to distinguish clinically or radiologically, and you need to do biopsy to know for a fact that this is benign or malignant. As we covered before, so you need to send fresh as well as fixed biopsy. This is rare, but I noticed it in one case that anterior extension of the mass beyond the orbital rim, it signifies palpebral lobe involvement. Okay, I think we should stop here because we reached almost half. We have 50 more slides. So we haven't covered the lacrimal gland, but the rest of lacrimal gland etiologies, I feel a lot of points that I need to highlight. So it's better to postpone this to another session. So any time of the week, next week, I can present. I'll be more than happy to present it. And in the future, since we have this COVID-19 situation, if you have any defect or you want to discuss any oculoplastic related topics, I'll be more than happy to join you.
Yeah, thank you so much, Dr.
So we'll stop here. And Msha'il Ibrahim, whenever you have a fixed date, just inform me and we'll gather again inshallah. تمام؟
الله يعطيك العافية دكتور، شكرا جزيلا.
حياكم الله. I'm gonna stop sharing my screen عشان you don't know what's coming next.
شكرا جزيلا.
الله يحييكم.